have this? Yeah. So it's good to have a genetic team from doing ophthalmic genetics in PGI. So very fortunate and lucky that we are all of us are together here doing a lot of pediatric ophthalmology. So I would be presenting a case, two cases rather, in what we do in neuro-ophthalmology. Yeah. I mean, yeah, the phenotype is pretty clear here. It's just the genetic testing for why we get it done. So the finding of optic atrophy in a child is always a cause of concern because so many causes. I mean, it could be anterior visual pathway or the posterior visual pathway. So we do have improvement in diagnostic abilities related to neuroimaging and molecular testing. It's not always possible to get accurate results with electrophysiological testing in children. Obviously, they're so uncooperative. And confirmation with molecular diagnosis and correlating to the phenotype narrows down the differential diagnosis. So we have a 5-year-old child who complains of some diminution of vision, both eyes blurring, the way children would tell. Since 3 months, there's no pain or redness associated with it, no pain on ocular movements. No complaints in the past, uneventful birth history, just this child is affected, nothing else. And then when we do the ocular examination, we find that the visual acuity is dramatically down. It's about 2/60 in both the eyes. The child is unable to read the demo plate even when you do the color vision testing. So basically, these are some of the clues where we find that there's some kind of an optic neuropathy which is going to be there. And so when you examine the posterior segment, what we see is a white disc. So the margins are relatively clear here. There is abnormal branching which is there from the disc. So it looks like a primary optic atrophy, although there is the pallor is developing in the other eye as well. So the number of causes which can happen to cause optic dyspallor in a young child, because we've seen this even with the children with the raised ICT, post-raised ICT, I mean having dyspallors, not just disc edemas. So when we do the OPD testing, because obviously we have to put this all together and try to fit in what we are dealing with. The OCT macula is all fine. The visual field, whatever the child is cooperative, you see the fixation losses are pretty high because obviously the child is with low vision. What can you expect? But yes, we do get a fair idea that something involving the center is there. It's like a central scotoma which is coming up in both the eyes. The visual field testing, if you see the nerve fiber layer, it's decreased just 52 and 58 here. And so is the ganglion cell layer. It's quite less. So basically something has been there for quite some time. So now we start to take a retrospective history because a lot of neurological issues also which we were suspecting. So there's no such problem. There's no weakness of the limbs or paresthesia, no headache, vomiting, seizures, which could be the cause. So the impression is obviously a bilateral possibility, a primary optic atrophy. And what can cause this? Well, optic neuritis is again one of the causes, although there is disc edema, but the picture is not always clear. Then you have mitochondrial optic neuropathies like LHON, or you could have a nutritional cause. It's a bilateral optic atrophy, or it could be a toxic optic neuropathy. So basically all these things come into your mind. So had we sent this child basically to neurology or maybe to a pediatrician, probably a lot of things would have happened. So if we just see the differential diagnosis, basically we try to just narrow it down what is really happening, but in a child we can't really tell that if it's just one eye followed by the other. The child just has optic dyspallor and something which is a diminution of vision in both the eyes. So really can't tell what is going on. So we get a whole bunch of investigations to rule out whatever the simpler ones before going into more detailed investigations. And then we do ask the pediatrician to look up. The systemic evaluation is normal. They consider it as an optic neuritis and start treating with IV methylprednisolone. But there's no improvement, and then the patient comes back to us, and then what we order is what we call genetic testing. When we do the genetic testing, obviously we have to, the genetic testing is an older one because obviously we could get it done at a much lower rate. So the child is positive for 11778A mutation, which is seen in LHON. Now LHON also has 3 types of mutations. So this one has a grave prognosis, so that's not really good. So we start the child on coenzyme Q basically after taking the pediatric consultation, but the visual acuity really doesn't improve here. So what we can do here with genetic testing is just basically prognosticate it, what is happening, and maybe had just been one eye being involved, probably we could have, this treatment would have helped us in salvaging the other eye visual acuity. But here, just prognosticating, that's what really helped us, and not going into any systemic problem with the child sometimes can have with these LHON, like a neuropathy or a myopathy. So the second case is a 10-year male with bilateral progressive decrease in vision since 3 years. Everything else is unremarkable. The visual acuity is 636 and 660. Pupils are fairly good reacting, normal size. Anterior segment is fine. And the posterior segment, again, we see what the disc, it is a disc pallor. And here what we have is a temporal disc pallor. So it's a temporal disc which is affected more as compared to the nasal part. And so when we do this electrophysiological testing here, there is a prolonged latency of the P wave. Again, with the low visual acuity, sometimes really difficult. Again, in a child, it's difficult to pick up a visual field, but yes, there is some signs or clues which are coming up to that the child does have a central scotoma. So these are some of the clues what we get. Again, the optic neuritis is really something which is always the first on our list, basically. So it's a 10-year-old, so we get all these NMO-MOGs done, it's negative, OCT macula is fine, MRI does not show up anything, then the next step is obviously genetic testing. And when we do the genetic testing here, what we find is a likely pathogenic variant in OPA1. So that's something here. Now we are having an autosomal dominant optic atrophy in this patient. The other patient we had LH1 was just a 5-year-old. Basically, LH1 would present later as compared to OPA1. So something when it's not really fitting in, probably, I think to know the diagnosis and to further narrow down your basically your differentials, a molecular diagnosis should be there. So basically 2 cases which highlight what the patient could have. And OPA1 usually has a better prognosis, whereas an LHON with the 11778 mutation has I mean, you can just guide them what they can do, because the prognosis is not really good in those cases. There are certain other mutations in LHON which probably have a better prognosis. There is also probably they do get back their vision in some of these cases. Thank you. So we are happy to have any comments or questions, anything, or we move on. What start on? Idibinon, yeah. So one thing is that the child already has very low vision with an optic disc pallor. The other thing is, in India, Idibinon is 45 milligram, which is available. You have to give almost 45 900 milligrams. And so Idibinon has been shown to have a good effect where the other eye is not yet affected, so salvaging the visual acuity. The other condition where it has been effective is the 11448 mutations, which has a good prognosis. In these conditions, it has not been shown to have a really an effective outcome, especially if in this case where you have you can have pallor in both the eyes with such a low visual acuity.